is why in India would people not do a cemented stem when everyone knows how well they work, everyone knows how good they are at restoring anatomy, but they're not used very often. And I think the reasons are, so I'm not talking about cemented cups so much. I'm happy to meet you in the middle. I now do a lot of hybrid hips. My elderly patients get cement both sides, but most of my hips now are done with hybrid fixation. And so when we talk about cemented hips in this talk, I'm talking more about the stem itself. So when you ask a surgeon, why do you not do a cemented hip? They'll tell you it's too hard, that it has an increased mortality, that it takes longer, that it doesn't work as well, that it's not consistent with modern practice, and why would I give my patients something that's historic and isn't really at the cutting edge of technology, and my patients want me to be this really cool guy who's at the cutting edge of technology. Perversely, they're often not expensive enough. Patients, particularly where you've got very well-off private patients, expect that the more expensive implants are better than the cheaper implants. There's a lot of argument that you don't use cemented stems in the young patients because they're not as good and they're too hard to revise. So I guess they're the things that, to my mind, are what stops surgeons doing cemented stems. So let's have a little bit of a look at that. We'll go through a sort of scorecard, and then I'll go through some of them in a little bit more detail. Too hard is false, and I'll show you why. In fact, it's much harder to do a good cementless stem than a cemented stem. Increased mortality is in fact false, and if anything, cement probably improves your survivorship. Increased time, yeah, no doubt it's a few minutes longer, but I always tell the story about, would a surgeon go to a tailor who says, I can make 4 suits in a day, they're more expensive, they don't work as well, and you won't get as good a function. And the surgeon would laugh at the tailor and say, don't be stupid, make me one that takes a little bit longer but works better. And the surgeon then goes to the hospital and does an operation that is quicker, doesn't work as well, and compromises the patient's outcome, but does 4 in a day because they make more money. So it's a complete contraindication to what you'd actually accept to yourself in life. You would never pay more for something that doesn't work as well just because the vendor can do more. But that is really the argument when you say it takes me longer to do a cemented hip. Increased failure is false, and I'll show you that. Not consistent with modern practice is false. It's actually the Exeter stem is the fastest growing striker stem in the United States of America. It's the biggest selling stem in the UK, biggest selling stem in Australia, and the C stem and other modern polished tapered stems are a very large part of modern practice. Yeah, it's not expensive enough, but do you really want to pay more for something that doesn't work as well? It's definitely good in the young, and it's definitely easier to revise than a cementless stem. So let's explore just a couple of those in a bit more detail. Modern practice, you can see here in Australia, the Exeter stem dominates. We've got a C stem, we've got a CPT, Quadra. So cemented stems actually are very common in modern practice in countries where we have registry data that says how the implants are performing. So you're not compromising your patients by doing a cemented stem. And finally, we're starting to see this little bit of a shift where the hybrids are starting to tick back up and the cementless stems are starting to tick back down. And I expect that to continue over the next years. This is a graph of a patient receiving a stem with a fractured neck of femur. Now, which one is easier? The one that has a 1% 7-year revision rate, or the one that has an 8% 7-year revision rate and a 4% 1-year revision rate? And the answer is, it's the cemented stem. If you get a better result and you don't get these disastrous early failures, this is easier to do. It's completely logical. You cannot argue that a cementless stem in an elderly osteoporotic bone is easier to do than a cemented stem, based on fact. And interestingly, everyone thinks, oh, I've got to be a high volume surgeon. 274 surgeons in this year in Australia did less than 10 exeters, and about 110 did one. And almost none do more than 100. Yet it's the best performing implant on the registry. And that says you can be a low volume surgeon and get outstanding results with a cemented stem. Therefore, it must be relatively easy. This is the Australian registry on patients under 55 at 12 years. Absolutely no difference between cemented, cementless, and hybrid stems. So, if anything, the worst is cementless and the best is hybrid. So, in young patients, cementless stems at 12 years are not doing as well as hybrids. And in fact, they're highly significantly worse and 40% more likely to be revised in patients under 55. The only logical conclusion to this is cementless stems do not work as well as cemented stems in young patients. They both have the same cups. The only difference is the stem. You cannot argue any differently than you tell your patient, if you're under 55, you're 40% more likely to have a revision by 12 years. And then when you get old, cementless, highly significantly worse. And we need to tell our patients the truth. And the truth is, cementless stems in all age groups do worse than hybrid stems, hybrid hips. Mortality, there's been a lot of talk about mortality. We published many years ago, and we showed you're more likely to be dead at a year if you get a cementless stem than if you get a cemented stem. Most studies show an increased mortality at a day. It's usually reversed by a week, and usually by a year, it comes out in the advantage of cemented stems. And there's lots and lots and lots and lots of papers that say the same thing. Cement is not a cause of increased mortality. If I go to the theatre and I've got a well-fixed uncemented stem, I know I am going to have a horrible day at the office. The femur is going to be in 10 pieces. There'll be osteotomies. It'll be horrendous. Revising a well-fixed cementless stem is one of the hardest things you can do as an arthroplasty surgeon, and you destine your young patients to really, really difficult revisions. Whereas we'll talk about in the next talk, if you do a cemented stem, you tap the stem out, you do a cemented cement revision, you can revise your femur in about 10 minutes. So there's really no rational reason to not cement the stem in every hip replacement and hemiarthroplasty. And to not cement the stem because it costs you a few minutes of time is actually selfish and not in the best interest of the patient. And these stems allow you to do really complicated anatomical reconstruction without doing extensive osteotomies and risking further complications. So the evidence is overwhelming that the reasons people are not doing cemented stems are not supported by science, which makes them non-science or nonsense. Thank you.